Hello guys, welcome to your own YouTube channel, The Clinical Show. Today we'll be discussing about an interesting topic that is auto PEEP, right? So let us understand what is a PEEP. It is simply defined as any positive alveolar pressure above atmospheric pressure, right? So any positive alveolar pressure that is beyond the normal atmospheric level, it's also is called PEEP. So it can be either external PEEP or internal PEEP or auto PEEP, also called intrinsic PEEP. External PEEP that is set by the ventilator or the mechanical ventilator. We set it in order to keep the alveoli open after end expiratory phase. But is auto PEEP that is the intrinsic PEEP. So that is secondary to incomplete exhalation or emptying of alveoli. So in any disease process or in any sort of pathology where the alveolar expiration or the alveolar emptying is incomplete, for example, in bronchospasm, in acute exacerbation of COPD or asthma, there is incomplete emptying, right? So it causes autopy. So what are the causes? As we have already discussed, when there is increased expiratory resistance, like in obstructive airway disease, like bronchial asthma, COPD, in bronchospasm, we have a kinked endotracheal tube. We have a ventilator circuit that is kinked. We have a HME that is clogged with blood or secretion that might also lead to excessive autopip that can be detected. Okay. Also, maybe some disease processes like emphysema, there is incomplete recoil that leads to incomplete alveolar emptying. So these are the processes that lead to autopip, right? So what are the consequences of autopip? When the intraalveolar pressure rises beyond a certain limit, it can cause a rise in intrathoracic pressure, which causes a decrease in venous return. As you all know, it leads to a decline in cardiac output, which causes hypotension. You might be seeing in your ICU or in ER a patient with acute exacerbation of COPD that comes with the shortness of breath, in a gasping condition, a severe tachypnea with respiratory rate of around 30 to 40, with a PCO2 of around maybe 70s. So after you intubate the patient, the patient suddenly develops hypotension. While intubating, you might have given some positive pressure breaths to the patient, and patient lands up into hypotension. So auto PEEP or intrinsic PEEP, excessive intrinsic PEEP might be the one of the causes of hypotension when especially the patient is volume depleted, as most of the patients in ICU or ER, they are not well resuscitated. We have to resuscitate them, right? So in volume depleted state, this adverse effect of auto PEEP or PEEP is significant. Okay, so we need to address the volume status for these patients in order to avoid hemodynamic instability or this kind of consequences, right? So also it can cause barotrauma, right? Also, there might be increased inspiratory work to trigger a breath. So let us understand what happens. This is a graph with X-axis here is time and pressure is in Y-axis. Okay, let us say patient is taking a normal breath like this, and second breath is initiated. So this is the, let us say it is the sensitivity setting, and that is set at minus 1 centimeter of water. So pressure sensitivity, flow sensitivity, there are another there to be discussed in another video. Okay, let us understand. So this is the circuit pressure as measured by the ventilator manometer. So what happens with auto PEEP? The alveolar pressure goes like this. So this is an inspiratory effort by the patient, and it does not touch the sensitivity line. So patient needs to generate this much of excessive negative pressure in order to trigger a breath. Hope you understand. Okay. So it will be difficult for a patient to initiate a breath and it will not be triggered. So patient tries to initiate a breath but it fails to trigger. So it causes exhaustion, it causes increased workup breathing. Then how do we detect whether there is an auto PEEP or not? It is detected with expiratory hold maneuver. So there is a button in every ventilator for this expiratory hold. So we have to hold this breath for 3 to 5 seconds. So what happens with this 3 to 5 seconds? The alveolar pressure and the airway pressure, they come into an equilibrium. Let us understand in the pressure time graph. This is pressure, this is time in x-axis, pressure in y-axis, and we have set a PEEP of, let us say, 5, 10, 20. So this is the PEEP of 5 we have said, that is external PEEP, PEEP external, right? So what happens? Ideally, in a healthy patient, when there is no auto PEEP, it should come like this, it should touch the PEEP line and next breath should be initiated like this. But with auto PEEP, what happens? This line do not touch and stay at the PEEP line, it increases to a higher level and then next breath occurs. Okay, so this new level, let us say this value is 8. So this is the total PEEP, and we have got this value after end expiratory maneuver for 3 to 5 seconds. Okay, so after air alveolar pressure and airway pressure come onto an equilibrium, this new equilibrated pressure that we get is a total PEEP. So here we get a total PEEP of 8, right? And what is the external PEEP we have applied by the ventilator? That is 5. So what is the auto PEEP? That is total PEEP minus external PEEP. So that is around 3. So Hope you understand. So total PEEP is auto PEEP plus the external PEEP. This is set by the ventilator, and this is intrinsic to the disease pathology, right? So in multiple choice questions, you can get a question like this: how do you measure auto PEEP with experimental maneuver, right? Also, also with the flow time curve or flow time graph, time in x-axis, flow in y-axis. What happens? This is the inspiratory phase. Then after the expiratory pause, what happens? It do not touch the zero line. Okay, ideally what should happen? Ideally in healthy individual it should go like this, then it should come like this, and next breath should get initiated. But what happens over here with auto PEEP? This line after expiration does not touch to the zero line. Okay, and next breath gets initiated. So with this you can detect there is some auto PEEP. So how do we deal with it? First of all, we need to measure. Yes, there is auto PEEP. So we have already discussed how we measure auto PEEP. Then we need to address the reversible causes. Like if there is bronchospasm, we need to deal with that with bronchodilators. If there is a small size ET tube, we can change it to a large internal diameter of endotracheal tube. We need to address whether there is some kink in the circuit or kink in the endotracheal tube is there or not. Also, we can change the HME if it is clogged with secretion or blood, right? So then we can disconnect the circuit, the ventilator circuit. We have to disconnect it. So what happens? The excessive air trapped, that is relieved. Then comes to ventilator setting. We need to address the ventilator setting individually, but the motto is we should target a greater expiratory time. We can have a lower tidal volume, we can have a lower respiratory rate. Lower respiratory rate allows more time for expiration. We can change the I ratio. If that is 1.2, we can do it like 1 is to 2.5 or 1 is to 3 or more, right? Also in some ventilators they do allow to manipulate inspiratory time or expiratory time individually. So when we keep the respiratory rate fixed and we decrease the inspiratory time, indirectly the expiratory time increases, right? So these are the maneuvers through which we can minimize or avoid auto PEEP, and we can avoid the hemodynamic consequences, and we can allow the patient to breathe comfortably. Okay, so this was a brief discussion regarding auto PEEP. Thank you so much. See you in the next video. Thank you. Bye bye. Take care.